So my name is Anissa Mitchell, for those of you who may be new to PMD Alliance, and this is part of our Lunch with Docs live streams. And today with us is Dr. David Shprecher. He is a movement disorders specialist, and he's director at Banner Sun Health Research Institute in Sun City, Arizona, which is a part of the Phoenix area. He's also clinical associate professor at the University of Arizona. And like I said, he's going to be talking about the differences between Parkinson's and Parkinsonisms, which I know a lot of people are very interested in. So I am going to welcome Dr. Shprecher, and I'm going to pass this over to him.
All right, just confirming one more time that my slides are showing. Got a thumbs up there. Wonderful. Well, I really appreciate you giving me the opportunity to update you about the difference between Parkinson's and Parkinsonism. I know it's been a very frustrating topic for a lot of people because very often they'll be told, we think you have some type of Parkinsonism, but we're still not sure exactly what the cause is. And then there's this long, we call the diagnostic odyssey, trying to get in with a specialist and get a straight answer. So today, what I'm going to try to do is give you a sense of how a neurologist determines the cause of these symptoms. I'll explain what Parkinsonism means. It's a set of symptoms. And then when we go through all these steps, what are some of the most common conditions that we're talking about when we say you have a Parkinson's plus syndrome or atypical Parkinsonism? I'm also going to touch on some of the emerging treatments for these conditions. And I know that's another very frustrating topic because there hasn't been as much movement in developing new treatments for the Parkinson's plus syndromes than there has for Parkinson's disease in recent years. But there are still treatments on the horizon and ways to get involved in helping to determine if those are effective and well tolerated. So Parkinsonism is a set of symptoms. In some cases, people will just have a tremor that's very prominent when the arm or leg is fully supported at rest, and it's dramatically improved with action. And that's one key feature of Parkinsonism, but not everyone with Parkinsonism has a tremor. The most important feature that really defines a Parkinsonism is this medical term, we say bradykinesia. And just to prepare the field for my next colleagues who will be speaking, that's another complex topic you'll have a whole separate talk on this week. But bradykinesia is one of the key features of Parkinsonism. And in plain English, it refers to an overall slowing down with activities that you normally do without thinking about. For example, writing or swinging your arms when you walk. On the exam, however, when you're seeing a neurologist, in particular a movement disorder specialist, we're looking for a reduction in the speed or the size, or we'd say in medicalese, amplitude of the movement when we have you do that, what one of my patients likes to call the dog and pony show, where we have you do the finger tapping and opening, closing your hands and rapidly alternating movements and so forth. So the movements get smaller and they may have arrests of movement that slow them down. That's what we're looking for to call it bradykinesia. And then we're also feeling the neck and the arms and legs to look for that muscular rigidity. And that's something people may experience in everyday life as a tightness or discomfort. So bradykinesia plus rest tremor or rigidity, at least one of those two items with the bradykinesia, is what we mean when we say you have Parkinsonism. People may also have balance problems that we can see on that kind of mean test we do when we pull you backwards and then make you catch yourself or catch you. In everyday life, when we talk about symptoms and the things that you're experiencing, people will experience bradykinesia. In some cases, it's just an overall slowing down where things just take at least twice as long as they used to, like getting dressed, getting ready in the morning, getting ready for bed in the evening. The handwriting may get smaller as you go along the page. We call that micrographia in your medical chart. Overall, impairment of fine motor skills can interfere with a lot of things like cutting food, doing buttons, tying shoes, for example. People who play an instrument find this can be very disruptive. But these are very important when you come to a neurologist, that you talk about which of these everyday activities are impaired. So that helps us decide whether you're responding to medication. Because one of the key ways that we define Parkinson disease versus atypical Parkinsonism is whether these symptoms improve with the Parkinson medication at an adequate dose. And that means with carbidopa, levodopa, if we're not seeing improvement with other medications. Now, in addition to improvement in the bradykinesia, we'd be looking for improvement in the muscle rigidity. Some people actually experience muscle stiffness or cramping or unexplained pain due to that muscle cramping. And that's an important feature we may monitor as well to look for really meaningful response in your everyday life to the levodopa or other Parkinson's medication. Tremor doesn't always respond as well. And again, we're looking more for rest tremor when we're considering, is this Parkinsonism something that's characteristic of Parkinson disease? People with other Parkinson plus syndromes often have tremor that's more prominent with activity. So just because you have tremor with activity doesn't necessarily rule out a Parkinsonian condition if you also have this bradykinesia with or without muscle rigidity. Another important feature that we're looking for is postural instability. So that pull test on the exam, but in everyday life, some people experience this as just dizziness. And whenever they're on their feet, they feel unsteady and that makes them dizzy. They also may start to have very frequent unprovoked falls. So not just that you left something in the way and tripped over it, but you just lost your balance and fell. So those are the symptoms that we're looking for and what we mean when we say Parkinsonism. But then what do we do once we say you have Parkinsonism? Then we have to decide what's causing it. One of the most important things you can do when you're seeing the movement disorder specialist for the first time is have a list of medications, not just what you're currently taking, but what you've taken in the recent past. Because there are certain medicines that can cause side effects of Parkinsonism. In particular, the mental health medications that are not just used for schizophrenia, but for depression and for bipolar disorder. These are in the antipsychotic family, but often used for other conditions like depression. Think drugs like Abilify, aripiprazole, Zyprexa, or olanzapine. Those are two of the most common that I often see that are a cause of the Parkinsonism. And it can take 6 to 12 months after stopping aripiprazole or risperidone or haloperidol before this Parkinsonism fully clears up for some individuals. So we want to know what you've taken at least in the past year, not just what you're taking right now. There are certain drugs used for nausea or for gastroparesis, which some people with diabetes have, that also block dopamine in the brain and can cause Parkinsonism. We want to see that medication list. Certain mood stabilizers, in particular, Depakote, valproic acid, or lithium. These also can cause symptoms that resemble Parkinson's disease, that are called Parkinsonism. And at least one of the heart medications has been linked to side effect Parkinsonism, amiodarone. We also want to ask about what you've done in the past, and we don't necessarily want to know every chemical you've ever handled. But if you were a welder and you did not use a respirator when you were welding, you could have manganese fumes deposited in your brain, causing a syndrome that resembles Parkinsonism called manganese. So that's very important to let the neurologist know if you were a welder in the past, because that will prompt us to do an MRI scan and look for manganese in your brain. The other important things we want to know, and I know sometimes you only have a short visit, you may have half an hour or less to tell your whole story and all the things that are important. There are three main symptoms that are going to be important for us to decide which cause of Parkinsonism you have if it's not a side effect of a medication or due to welding history. And these are longstanding problems with a sense of smell, chronic constipation, or recurrent dream enactment behavior. These three symptoms can often occur years before someone is found to have Parkinsonism. And there are only certain Parkinsonisms where these are very common as prodrome. So those are the top three symptoms you really should be prepared to tell the doctor about if they've already been there for a while, even before your other neurological symptoms started. Your family history is also important. Again, we don't need to go in detail about every single medical condition, but anybody diagnosed with a tremor or Parkinsonism type condition or dementia, even motor neuron disease like Lou Gehrig's disease, those are all really important because there are genetic conditions that can cause conditions that may include Parkinson's disease, but also the atypical Parkinsonisms, the Parkinson plus syndromes. And that may prompt us to recommend specific genetic tests that would explain not only your condition, but why it runs in the family and what future research is going to be relevant to other family members who are at risk because of this gene being in the family. So family history is very important to have available specific to Parkinsonism, tremor, or dementia when you see your neurologist. So when we see someone who has had longstanding history of those three non-motor issues that I mentioned, who has very one-sided or at least asymmetric symptoms where it's much worse on one side than the other, the tremor is very prominent at rest. In particular, if the foot is shaking by itself out of your control, that's a big red flag. This is likely something in the Parkinson's family, most likely Parkinson's disease. And once we start carbidopa-levodopa, and in some rare cases, if you have a young onset, even start other Parkinson medication at a sufficient dose, if we see dramatic, at least 60% improvement in your symptoms, and that's where talking about targets of therapy and what everyday activities are affected, that's another important factor that helps us say whether Parkinson's disease is likely. The other important thing, besides looking for that asymmetric onset and response to the medication once you eventually start it, is whether that response to medication continues over a series of a couple of years of follow-up. That's where we can't always say on the very first visit for sure what you have. We need follow-up to see how everything evolves. The other important thing is we're looking at the beginning for certain red flags. So if you are already noticing serious problems with memory, attention, ability to multitask, visual spatial skills where you're getting lost uncharacteristically or misjudging steps and falling because you can't kind of tell where the step or the curb is, if you're having severe recurrent falls, if you have severe autonomic problems like low blood pressure when you stand up where you feel like you're going to faint or actually do faint, if you're having trouble reading, and we don't want to hear about every eye condition you see your eye doctor for, we can go on for 10 minutes about that, but if you're having trouble reading because you can't look down, that's another big red flag for an atypical condition. The other thing is if the symptoms have very sudden changes all at once, like a stroke, that may prompt another evaluation, like an MRI. And then if there's a severe cramping up of one hand where you can barely use it, or you can't remember how to do certain activities, it's like your brain is losing that program of how to use a remote control or how to use a pen or how to use a utensil. We call that apraxia. Those are all red flags that will prompt us to think about other conditions. Another very important red flag that some neurologists often miss, but you need to point out and ask for more testing, is if the symptoms are restricted just to the lower body. If you just have trouble walking, but there's no problem in your upper body, that's a big red flag. This could be one of these other conditions, vascular Parkinsonism or normal pressure hydrocephalus. For example, if we do an MRI and we see something like this is an example of someone who at the very top of their brain, all that bright area is white matter that shouldn't appear bright on the MRI scan, where that myelin, that insulating material that covers connections between cells, is worn down, likely due to circulation problems. There are potential other explanations, but if the trouble walking came late in life, most of the time this has to do with a problem in the small blood vessels that supply that myelin. And so the signal just isn't getting down from the brain cells that control your legs down through to your feet. It's basically the wires are frayed. If we see a stroke on the MRI in an area that could cause symptoms that resemble Parkinson's, that could also explain the symptoms, and it might also explain why you're not responding to medication as you should, if it's in an area of the brain where the kind of the receptors that respond to dopamine are basically destroyed by a stroke. Another important thing we're looking for is something like this. This is the center of your brain. These dark spaces are chambers in your brain that hold the fluid that bathes the brain, the cerebrospinal fluid. And the fluid's not being drained properly, and it's building up and pressing on those fibers that control the legs. And so people can just have trouble walking. They may also have bladder urgency, even urgent incontinence, and trouble thinking clearly. So there's this triad that we teach medical students to look for. People are wet, wobbly, and wacky. They have bladder incontinence, they're having trouble walking, and they're unsteady on their feet, and they're having trouble thinking clearly. And when we order the MRI, we may do a calculation, kind of dividing the widest part of those ventricles by the widest part of the brain. And this is something the neurologists who see a lot of movement disorders will be thinking about and calculating themselves, if the radiologist hasn't already done it for them, to decide if you might have normal pressure hydrocephalus. And this is important not to miss, because this is one of the only treatable causes of this gait problem. All the other conditions we're talking about today don't have an effective treatment. They still progress over time. But the normal pressure hydrocephalus, with a shunt that's placed into the brain to drain that fluid, ventricular shunting, can provide long-term benefit to control that trouble walking. So the MRI or CAT scan are very important to have done if your symptoms are just restricted to both of your legs, if you just have trouble walking and nothing else. Another test that may be used in select cases is the DAT scan, and that stands for dopamine transporter scan. This labels the nerve endings that release dopamine in the motor circuits of the brain. And if they're damaged, they won't light up appropriately on the scan. If the scan is normal in the right hands, meaning a center that has special training for the radiologist how to interpret the scan, and that radiologist focuses on interpreting these regularly, a normal scan from a reliable source may help us determine if a medication you're taking that's on that list that I provided earlier, and it'll be on the slides we share. If you're taking one of those medicines, it can help determine that, hey, this could just simply be a side effect of one of those medications and not due to degeneration in the brain. If you just have tremor with activity and you don't have a lot of those other Parkinsonian symptoms, it could help confirm a diagnosis of essential tremor. And in some cases, people have something called a functional movement disorder, and the scan may be useful in select cases where that's suspected, but things aren't quite adding up. There is a biopsy test that's starting to be used in select cases. It is not by any means a substitute for a careful history, medication list review, and examination. But if someone has Parkinsonism and this biopsy is done and shows synuclein in the nervous system, this could help support the diagnosis of synucleinopathy. So what is synucleinopathy? Synuclein refers to alpha-synuclein. This is a protein that's involved in storing dopamine and other brain chemicals. And it's not exactly clear why, but in some individuals, the neurons, the brain cells, are not recycling the synuclein properly, and it aggregates, it clumps up, and it's thought to cause a process called the neurodegenerative cascade, where there's damage to the brain cells and they degenerate and eventually die off, particularly in the dopamine producing neurons. And that's why motor symptoms are an important feature leading to the diagnosis of Parkinson's disease. Now, people with Parkinson's disease, we see that synuclein in an accumulation called a Lewy body that can be seen just with a regular microscope slide with special stains. And those Lewy bodies are very characteristic of Parkinson's disease and the other Lewy body disorders. The other important Lewy body disorder is dementia with Lewy bodies, which at an autopsy is indistinguishable from someone who had Parkinson's disease, but it's diagnosed based on the history of someone having severe cognitive decline in their first year of symptoms, leading to a diagnosis of dementia. In some circles, dementia with Lewy bodies is viewed as just a more aggressive Lewy body disease, so a more aggressive form of Parkinson's. Many people will hear the term Lewy body dementia thrown around, and that's a whole separate topic that we already have recorded and posted on the YouTube channel with the PMD Alliance. But Lewy body dementia refers both to the dementia later in the course of Parkinson's, or in someone who has that more aggressive form dementia with Lewy bodies. Now, in some cases, the alpha-synuclein accumulates in other cells called the glia. The glia make up that myelin sheath, for example, that insulates connections between cells. And the synuclein aggregates are in those cells, and it seems to cause a lot of inflammation in the brain that then leads to earlier and usually faster loss of brain cells. So it does lead to loss of neurons, but because of that accumulation in the glia, leading to inflammatory cells in the brain. The other category of atypical Parkinsonism, you'll see this term in your chart. If we're thinking about this condition, we call it tauopathy. We sometimes call it a 4-repeat tauopathy because of the specific form of this protein that makes up the cytoskeleton. So basically the skeleton of those main cells of the brain, the neurons. When that protein comes off of the cytoskeleton and starts to aggregate or clump up, this causes damage to the cells. It also may cause damage to the circulatory system of the cell that moves things up and down the long part of the cell called the axon. There are two main flavors of tauopathy: the progressive supranuclear palsy, called PSP for short, and corticobasal degeneration, called CBD for short. So this is where it gets really complicated, but when you see a specialist, depending what you're seeing them for, movement disorder or dementia, when you see somebody who specializes in these conditions, they'll often refer to diagnostic criteria that have been well established, where if someone meets all the criteria, we can say with a relatively high level of confidence that if you donated your brain to science and we got a definite diagnosis based on an autopsy of the brain, that you would actually have the condition we suspect. And with dementia with Lewy bodies, the diagnostic criteria were recently updated in 2017 after about 15-year period, or actually from 2015, so 12-year or so period since they had been updated, 2005 to 2017. One of the key features is there's cognitive decline leading to dementia that's noted in the first year symptoms. Most of the time, it is not just memory loss, but problems in other domains like attention, multitasking, known as executive function, or visual spatial skills. And then what we're looking for is at least 2 out of these 4 core features. So Parkinsonism is on there, acting out one's dreams while asleep is on there, but it has to happen on a regular basis. Visual hallucinations, if they've happened on a regular basis, not just one time when you're taking pain medicine or one time when you're in the hospital, but on a regular basis. And then the other core feature is known as a cognitive fluctuation, where people can have profound spells lasting minutes to hours, even a whole day, when it's like they're in a fog, or they're just really out of it, and they have very impaired attention or level of alertness, but other times they're almost back to their normal baseline. So profound fluctuations in their alertness or inattentiveness. And that's not just the sundowning at night where people get confused in the evening and then they're better in the morning. Now, in some cases, people only have one of those core features, or it's very subtle, like just a trouble walking, but not a true Parkinsonism. So we need something more than that. And that's where the DAT scan is a biomarker that can help count as one point towards those two items to help make a diagnosis with a higher level of confidence. The other is getting a sleep study where we confirm that this is something called REM sleep behavior disorder, where the muscles that should be relaxed during rapid eye movement stage of sleep are not. And that would help make a diagnosis of REM sleep behavior disorder. It's another important biomarker that would point towards a synucleinopathy like DLB, dementia with Lewy bodies. Now, there's a test that's not widely available in North America yet, and it's unclear if centers have an appropriate protocol for interpretation, but it's widely used in Japan and in some parts of Europe, where it looks for a loss of sympathetic nerves to the heart that produce a different nervous system chemical called norepinephrine. And the short acronym for that test is MIBG. That also can count as a point towards this diagnosis. Now, the thing that's complicated is we know from multiple autopsy studies that people who donate their brain and turned out they had dementia during life, when they're found to have dementia with Lewy bodies at the autopsy, majority of them have a combination of both dementia with Lewy bodies and also Alzheimer's disease. Another important challenge is that in many of these brain bank studies, there are a lot of people found to have dementia with Lewy bodies at an autopsy where the diagnosis was never detected while they were alive. So even though most people who meet those diagnostic criteria to where we can call it probable dementia with Lewy bodies actually have it, it's not sensitive enough. There are a lot of people who have dementia with Lewy bodies, but they're not accurately diagnosed. It may be, however, that those people have not seen a specialist. So this is where, if you have an unusual case where there's early cognitive decline, we're trying to determine what the cause of that dementia is. It is important to see a specialist to get an accurate diagnosis. Now, why is the diagnosis important? Well, beyond prognosis, because this can be a more aggressive illness, the treatment's going to be a little different. We're going to be much more careful using Parkinson medication if there are motor symptoms that warrant the medication. We might use lower doses of carbidopa-levodopa. There's also a medicine called zonisamide that is approved for Parkinson's in Japan, but is approved as an epilepsy drug in the US. We might be more likely to use that if you have dementia with Lewy bodies, because there's evidence that it can be well tolerated and be helpful for motor symptoms in DLB. Now, when you see a specialist, they're going to try to avoid amantadine or trihexyphenidyl, but a common mistake I often see with general neurologists is they'll use amantadine in this population, and it's much more prone to bringing out hallucinations in people with DLB. In particular, trihexyphenidyl is also very prone to bringing out hallucinations and worsening the dementia problems. If you have DLB, then we're going to be even more likely than if you had Alzheimer's to want to start a memory enhancer early, because it may be very helpful not just for the cognitive symptoms, but for hallucinations or acting out of dreams as well. And you may respond better to it for the cognitive symptoms than if you just had Alzheimer's. We'll also be even more vigilant about having your doctors avoid antipsychotics, because it can cause profound worsening, not just of the motor, but also the cognitive symptoms of DLB. Another important thing that we would monitor for more carefully if we made a diagnosis of DLB is a problem with low blood pressure when you get up and down. People with DLB are very prone to this orthostatic hypotension problem, even more so than people with run-of-the-mill Parkinson's. So there are two main treatments that are in clinical trials in North America. The one that just launched most recently is a medication that showed promise in a small study, but it was found that when they did a spinal tap and looked for signs of Alzheimer's, which we can detect in the spinal fluid, people who had both dementia with Lewy bodies and Alzheimer's did not respond to the medication, but it looked like people with the pure DLB were responding. It's just the study wasn't designed to focus just on those people. So we can't say for sure. Now we need a larger study, and they're going to screen people with this, looking at their spinal fluid, decide if you have pure DLB. And if you do, then you would continue in the study. And this medication seems to help with that circulatory system of the neurons I mentioned earlier, where things moving up and down the long part of that axon, that long part of the cell called the axon, that's important for nourishment and function of the cell. So that's how it's thought that it may work. And this is kind of outlined in some of their recent publication that I outlined in the slides, which will be made available to you. The other medication is got just an acronym because the company name acronym is CT, so CT1812. So this medicine, basically what it's thought to do is block the neurons from absorbing that aggregated, misfolded alpha-synuclein, but also potentially the beta amyloid from Alzheimer's, from absorbing the toxic forms of those proteins, which can then interfere with their function, damage them, and ultimately destroy those brain cells. So that's how that one's thought to work. Both of these studies are listed on clinicaltrials.gov, and I listed the study numbers on the slides. You'll be receiving a copy of those after today's talk, and the talk will be recorded. But I encourage people to go to clinicaltrials.gov if they're interested in learning more about any of the studies I'm mentioning. Once the studies are posted, and these two already are because they're actively recruiting, it'll also have contact information for all of the sites, so you can contact the one that's closest to you. Now, I'm not going to go into exhaustive detail about all the criteria that we use for these other Parkinson plus syndromes, but I'm sharing these so that you can see how thorough and involved this process is when we try to decide if your Parkinson plus syndrome is a specific condition. For example, for multiple system atrophy, we call it multiple systems because 2 out of 3 systems have to be involved. So the motor system is one. That's where the term Parkinsonism is important because that shows involvement in the motor system. The cerebellar system is another, and the symptoms we're looking for are ataxia, coordination problems. And then the third symptom, there's a third system involved, is the autonomic system. And what we're looking for to decide if you could potentially have multiple system atrophy is in someone who doesn't have dementia, because if you have dementia, we're thinking about dementia of Lewy bodies. And someone who doesn't have dementia, we're looking for severe orthostatic hypotension, where the blood pressure drops at least 20 points systolic within 3 minutes of standing up, or unexplained urinary incontinence. So if you have the autonomic problem, and then you also have cerebellar ataxia or Parkinsonism that's not responding like it should to levodopa, or the response is waning over time, that would raise concern for multiple system atrophy. And then we need to see at least a couple of other key features before we can say that the diagnosis is established. In particular, to say it's established, we also need to see certain features on an MRI scan. So MRI scans are not just useful to look for vascular Parkinsonism or normal pressure hydrocephalus, but there are specific features we're looking for on the MRI. For example, there's something on the right-hand side. If you look very carefully at the very center, there's something that looks kind of like a plus sign. We call it the hot cross bun sign because it looks like these hot cross buns that are popular in the United Kingdom. On the left side, there's kind of a saggy belly to that bird-like structure, the brain stem. That saggy belly is atrophy of another area of the brain called the pons. So those are examples of things we're looking for on the MRI. If the MRI doesn't have the key features, we can still say this is probable multiple system atrophy if we have at least a couple of other features that are listed here, things like severe swallowing difficulties early on, involuntary emotional expression, where you laugh or cry when you don't mean to. Exam findings like a jerky tremor called myoclonus, or a Babinski sign, where when we tickle the bottom of your foot, the big toe goes up when it should be going down. Even that discoloration in the hands and feet from circulation problems. These are examples of things where we're looking for at least one of these to say probable, or two to say it's clinically established. Now, one of the studies that's recruiting people that I'm aware of that was recruiting people with multiple system atrophy was testing a possible treatment for the orthostatic hypotension problem in multiple system atrophy. The other one that's just getting started, so there are only a small number of centers listed on the clinical trials website right now, is actually doing a surgery where a virus is injected, where the virus is inactivated in a way that it doesn't damage the cells, but it inserts certain type of DNA in the cell that produces a chemical that tells cells to stay alive. It's called glial-derived neurotrophic growth factor, GDNF. So this is something we call gene therapy. And there's a company that's just launching it right now. So the clinicaltrials.gov listing will have more details about what's involved in the study and which sites are currently enrolling. But that will be updated periodically as new sites get involved. The other important Parkinson plus syndrome, and that's the first one of the two in that tauopathy category, is called PSP for short, progressive supranuclear palsy. It's considered the second most common neurodegenerative cause of Parkinsonism after those Lewy body diseases, Parkinson's and dementia with Lewy bodies. It also has a triad that we teach our doctors in training to look for, or neurologists in training to look for, and that's a problem looking vertically, so vertical gaze palsy, atypical Parkinsonism, where there's poor or waning response to levodopa, and the symptoms are usually similar on both sides, so more symmetric, and then early postural instability, where there are recurrent unprovoked falls or severe problems on that pull test, where often we have to catch you because you're not able to catch yourself. It also can start with a specific type of cognitive problem we call frontotemporal dementia, where there are serious problems with language or behavioral changes, but not memory loss. And on the MRI, there are things we're looking for. On the left-hand side, the beak of this bird here is very narrowed. We call that the hummingbird sign or the penguin sign. And on the right-hand side, the base of the flower or the Mickey Mouse there is much thinner than it should be. So we call it the morning glory sign or just the Mickey Mouse sign. And these are things that we're looking for on the MRI scan. If all the symptoms fit, it'll help support our confidence in the diagnosis. But we're also looking to make sure that if there's a cognitive issue, that it's not just memory loss, which makes us think more about Alzheimer's disease. And we're usually not expecting to see severe autonomic problems, which we would see more in multiple system atrophy or dementia with Lewy bodies, particularly that orthostatic hypotension problem early in the course. We wouldn't expect to see it early in the course of PSP. And there are other features that we'll look for that would point to one of these other conditions that would be an exclusion. Now, what's tricky is only about 25 to 30% of people with PSP have the textbook presentation that we teach people about. It's named Richardson syndrome for the lead author on the first series of cases published in the late 1960s when PSP was first described. But there can be a Parkinsonian variant where people initially do look like they have Parkinson's and do initially respond to levodopa, even have acting out of dreams. There can be a frontotemporal dementia variant where people start with frontotemporal dementia and develop the other symptoms later. And another important form is where people mainly just have gait problems at the beginning with gait freezing. So this is another example where if it's just lower body Parkinsonism, that's a big red flag. This is probably not run-of-the-mill Parkinson's disease. It could also be a subtype of PSP. Now, both PSP and multiple system atrophy are more likely than Parkinson's, to cause involuntary emotional expression disorder, where people laugh or cry too much when they don't mean to. And there is a specific medication available. It's a combination of dextromethorphan and quinidine that can be quite effective for that symptom. So that's the main symptom of the atypical Parkinsonisms, where there is a specific treatment available. What we don't have is a proven therapy to slow the progression. One big setback was all the studies to date that were testing antibodies to block spread of that misfolded tau protein from one cell to another. None of those studies were successful. So there's a company called Amylyx, and the actual spelling is in the slide below. They recently had a public presentation to their investors, and on their website, you can actually watch the recording of that, where they talk about the drug that already has shown promise in other neurodegenerative conditions, which they're now planning to do a clinical trial for PSP. It's a combination of two medicines, phenylbutyrate and torocidile, that in combination also appear to protect the brain cells from dying off, and it may also reduce production of that tau protein that tends to accumulate and misfold. Another approach, it's a much smaller study, that's just exploring an injection into the spinal fluid to actually give something called antisense oligonucleotides that would block production of the tau protein. So I think this first one will be a larger trial. It's not listed on clinicaltrials.gov yet, but it will be once the first sites are selected, once it launches later this year. The other one is listed on clinicaltrials.gov for that smaller spinal fluid injectable medication approach. And then the other type of tauopathy is called corticobasal degeneration. However, your neurologist will usually use the term corticobasal syndrome because the accuracy of the diagnosis based on these symptoms is much lower to predict the underlying cause. The symptoms we're looking for are that severe kind of twisting posture of the hand called dystonia, or apraxia, where there's a loss of that motor sequence of how to do everyday activities. We're also looking for a jerky tremor we call myoclonus. We're also looking for something called alien limb that's less frequently present, but when it happens, it's like your hand just has a mind of its own, and you may just kind of hold it in the air without knowing that you're doing it. But when we see 2 out of 3 of these symptoms from each column, that helps us say this is a corticobasal syndrome. That's more likely than not to be a tauopathy. Tauopathy meaning it could be from the corticobasal degeneration or PSP, because PSP has a subtype that can look like this, and those are considered closely related disorders. However, if someone has memory loss, it could turn out to be Alzheimer's disease. If someone has orthostatic hypotension or hallucinations, then more likely it's going to turn out to be from dementia with Lewy bodies. And there is another type of frontotemporal dementia that differs from the other conditions that also can present this way, as can prion disease. So I mentioned that another important reason for us to give you a more accurate diagnosis is because of prognosis. Now, the numbers I'm posting here are scary. I want to, just acknowledge that. These are the averages that have been reported. There are definitely outliers, people that progress more quickly and people that progress more slowly. But people who have atypical Parkinsonian syndromes progress more quickly and actually are likely to pass away due to their illness within particular average timeframes, whereas people who have run-of-the-mill classic Parkinson disease may often live a normal lifespan, unless they progress to an advanced stage where they have very severe symptoms. Often, in those cases, they're complicated by dementia and hallucinations, for example. But not everyone with Parkinson disease has an end stage. People with the atypical Parkinsonian syndromes all do get to an end stage where, because they're so advanced, they die from complications of the immobility from the illness or from complications related to falls and swallowing problems. So this is why it's important to know not only if you have an atypical Parkinsonian syndrome, but which type you have. So then we can give you estimates on expected prognosis, time to severe disability, so that you can plan when you're going to need to be in assisted living or have a full-time caregiver available, someone to keep you from falling. And then just in terms of how to plan the remaining years of your life so that you know kind of this is estimated lifespan based on how my symptoms are evolving and my neurologist's experience in general and with me. So I hope that gives you a little bit more comfort in what it means when we as neurologists say you have Parkinsonism, or if we think you have atypical Parkinsonism, and the importance of having an accurate diagnosis of the cause of Parkinsonism, not just for the prognosis, but to guide us about what symptoms to monitor for and to manage. And just to point out that clinical trials are not necessarily going to benefit you directly, but volunteering in them is essential to speed up that process whereby we can determine which treatments are likely to benefit people with specific types of atypical Parkinsonism. Even if the study volunteering is not successful, then we're that one step closer to ruling that one out and then focusing our resources on the next most promising treatment. So in closing, I want to encourage all of you, if you or someone you love has one of these atypical disorders, to take advantage of the online resources. If it's Lewy Body, the Lewy Body Dementia Association is highly recommended. For all of the other atypical Parkinsonian disorders, the Cure PSP organization supports all three, PSP, CBD, and MSA, and may also have online support groups available. And there also is an MSA coalition with additional resource information for people with atypical Parkinsonism. And anytime you have any medical condition where you want to know what studies are going on, you can type in the name of the condition and also limit it to a specific region, like just the United States, which I recommend doing if you're based out of the US, and find out which treatments are actively recruiting for a particular condition. All right, well, thanks for having me. And we've still got a few minutes left for questions. So I'll hand it over to the PMD Alliance team to kind of choose which questions to start with.
Great, awesome. And we do have some questions, and I'm going to actually spotlight you so people can see you in the big crowd of everything that's on there, all the boxes. So we had quite a few questions that come in, and I guess I'm going to start with the ones around the diagnosis, because it sounds, you know, kind of complicated and challenging. One question was, with all the varieties of diseases and some of this symptom overlap, how often are patients misdiagnosed? And along with that, like, it can be, how can you help to improve accuracy? Because you were talking about, you know, it's important to know what you're dealing with for the right treatments. A person has shared that they had a family member who was diagnosed with Parkinson's initially and then had a DBS, and then later found out they really didn't have Parkinson's, they had MSA, which DBS is not indicated for. So I know that's very long-winded, but like, so around that, it's really important for that diagnosis.
Yeah, so there are a couple of important points from that question. First of all, there can often be a delay of a year or more before someone gets an accurate diagnosis of the cause of their Parkinsonism. One of the important challenges, though, is that you still need to have someone who can follow up with you. And in today's day and age, as long as they're in the same state or they're licensed in the state where you live, some of the follow-up can be by telemedicine to ease travel burden. But we need to see how the symptoms evolve and how you respond to Parkinson's medications in order to get to a point where we can use those diagnostic criteria to make a diagnosis with a higher level of confidence. The other important question is, well, how can we get a more accurate diagnosis earlier on? Well, hopefully I've given you some examples where if something isn't adding up, you'll seek an opinion with a specialty center. So if the main symptoms are Parkinsonian, you'd go to a center. It doesn't have to be designated as a center of excellence by a particular organization, but it should be a center where they focus in movement disorders or the neurologist that's leading the program is fellowship trained in movement disorders. That is an important factor that will lead them to use those diagnostic criteria more carefully because they're more familiar, they're using them every week, seeing lots of cases with Parkinson plus syndromes.
Awesome. And you did answer a question with that because there was one specific about going to a center of excellence. So one person wanted to know a little bit more about this DAT scan. So does a DAT scan measure the amount of dopamine in the brain or only the capability to transport the dopamine?
It's the second one. And it's tricky because some centers don't necessarily have a reliable interpretation. So the DAT scan is not a substitute for a good history and exam. I've had patients where they clearly don't have Parkinson's disease or anything in that category, and I look at the scan and it's normal. It was just misinterpreted. So it has happened where I've had to rescind the diagnosis of Parkinson's, someone who has essential tremor. But in the right hands, the DAT scan is an indirect measure of dopamine production because it's measuring that dopamine transporter that picks up the dopamine after it's released. So if the nerve endings releasing dopamine are intact, then the dopamine transporters that pick it up will be there as well. So it's an indirect measure of the health of the dopamine neurons.
All right, so this kind of goes along with that, and I'm not sure that I have enough information in this question, but I'm going to ask it. So they want to know if a person is 2 DAT scans over a 12-year period, both negative, can they still have a Parkinsonism or Parkinson's? I'm assuming that means that they have some kind of symptomology going on.
Mm-hmm. Yeah, if someone has had 2 consecutive normal DAT scans and it's at a reliable center that specializes in interpreting the DAT scans, then that tells us that the dopamine producing neurons are intact. Now, that doesn't mean you don't have vascular Parkinsonism or normal pressure hydrocephalus or drug-induced Parkinsonism, but it would exclude a neurodegenerative cause, meaning one of those Parkinson plus syndromes, the Lewy body dementia, multiple system atrophy, and then the tauopathies. But you still need to have a neurologist who understands how to differentiate those other causes of Parkinsonism and is thorough enough to do so. Because I've had some people where they literally only have 5 or 10 minutes with the doctor. It's not enough time to go to that level of detail in the history and exam.
All right, so around some of these other disorders, there was a question about whether, and I think you talked about maybe some overlap, but is it possible or common, I guess, to have a mixed diagnosis such as, can you have NPH and Parkinson's?
You can, and that's a tricky thing. We definitely have patients where they come to me, they have a shunt for neural pressure hydrocephalus, but now they also have Parkinson's. And if the shunt isn't working right and their walking gets worse and they have to have a shunt adjusted. So it's rare, but there are cases where someone can have both. What I usually see though is, and this is where it's an ongoing controversy what to do, if someone clearly has symptoms of dementia with Lewy bodies or progressive supranuclear palsy, even if their imaging and their response to a high volume spinal tap where we kind of simulate the shunt is a positive response, if we place the shunt, people continue to decline fast enough where they lose all benefit within 3 to 6 months. So I generally don't recommend pursuing evaluation and treatment for normal pressure hydrocephalus if you have those other features like the recurrent visual hallucinations of Lewy body dementia, the vertical gaze palsy, as well as severe Parkinsonism in the upper body that we typically see in PSP.
Okay, and I know we're very close to being out of time, but a couple of questions. And as far as the finding somebody who can do a reliable DAT scan, is there anywhere that someone can go that has a listing of that, or would you just say go to a center of excellence?
Yeah, it's different in every region of the country, but wherever I've practiced, this has always been a challenge. So you have to kind of defer to the movement disorder specialist that you're seeing as to which centers are most reliable in your region.
And just around, you mentioned vascular Parkinsonism. If someone has that, does it respond at all to Parkinson's treatments, any of the medications?
In the vast majority of cases, vascular Parkinsonism does not respond to medication therapies. So we're mainly looking at trying to prevent the next stroke or prevent circulation problems from getting worse. Like things like managing blood pressure and cholesterol, potentially taking aspirin, potentially exercise may be involved to try and address the trouble walking that you have. The one exception, I did have one patient where they had a stroke in the dopamine producing region of the brain, the substantia nigra, and they were responding to levodopa because they were just not making enough dopamine. In most cases, the stroke is elsewhere. It's in a part of the brain that responds to the dopamine. So it's just knocked out and it can't respond to it. Or it's in that white matter where the signal's just not getting through to the feet. In those cases, we generally don't see a response to levodopa.
Okay, and you've talked a little bit about the brain autopsies and what they were diagnosed with, what they actually might have had. So someone wanted to know, from the brain bank, did PD brains actually have low dopamine levels, or what did you see in those? Did they actually turn out to have PD like they suspected?
Yeah. What we're finding is people who have had Parkinson's disease for at least 10 years, diagnosed with Parkinson's, and they're responding well to medication for 10 years or more. Greater than 90% of them turn out to have Parkinson's disease. What are some potential misdiagnoses? It could be the multiple system atrophy, for example, PSP. In some cases, a side effect of a medication that we didn't think was enough to explain their symptoms, but in the end, it actually was. In one case, it was valproic acid, Depakote, which was a big surprise for, I think there were 3 or 4 specialists that all said Parkinson's. So misdiagnosis still can occur, but then in hindsight, there's something that we missed. The other thing that we see is that if we measure the dopamine producing nerve endings, most of that damage to those nerve endings seems to happen in the very first 3 or 4 years of Parkinson's symptoms. So people who pass away later than that, the damage already seems to be kind of at its peak. And so it's not fully understood what leads to that additional progression over time.
Wonderful. Well, I know we're out of time. I know you have a busy clinic day still ahead of you, so I want to protect that. And I want to thank you so much for this wonderful information. He did drop some resources. We tried to add those in the chat. So if you want to save your chat, grab that, and you can do that by going over to the little dots at the bottom of your chat box and clicking that, and it says save chat. You're also going to be able to access the slides, which will have those resources on there. If you are someone that's dealing with one of these atypical Parkinsonisms, as Dr. Shprecher mentioned, there are resources available to you. They do have different ones for the Lewy body dementia. There's the Cure PSP and the MSA Coalition. So check those out. That's part of the resources he mentioned, because they may have some specific resources and support groups and things for you. And of course, PMD Alliance always welcomes you into any of our online communities as well. But if you want to be with others that are sharing your same diagnosis, we encourage you to check those out. So I want to thank you, Dr. Shprecher, so much for giving us the time and your expertise. And in PMD Alliance style, I'll invite everybody to give you the wave of gratitude to send you off with thanks. So thank you. And thank you everyone for joining us, and we will see you next time.